So really going back to the basics, I'm going to start as we mean to go on, and that is someone else giving one of James's talks. So normally you'll find that most of the talks today, maybe even all of them, will have been written by James. And James, I think, single-handedly is I mean, he really is the leading CTO educator for the world at the moment. Maybe of the universe. So, here's some new terminology for those of you who are non-CTO operators, but this really is a reflection of how CTO treatment has evolved over the last 10 years with the introduction of antegrade dissection re-entry. So, the initial strategies used and the final strategies used. So this is really a split between this large block here is what most people were doing CTOs before CTOs became a thing again, were doing antegrade wire escalation. And then what was introduced then was retrograde, and the sort of fundamentals of retrograde were then being learned around sort of 10 years ago. And then when the concept of working in the subintimal space then was introduced with Stingray, then we began sort of classifying both the antegrade and the retrograde approaches into antegrade wire escalation, retrograde wire escalation, antegrade dissection, so going into the subintimal space and then getting back in, and antegrade dissection re-entry, and similarly retrograde, which is, we were thinking about reverse cart. It's essentially the same process going into the subintimal space and then coming back in. And so this is really a split between how this is our initial strategy, so most cases start off as antegrade wire escalation cases. And as we're going through the escalating difficulty of anatomy, and as you're starting in your CTO operator experience curve, you're going to be starting with antegrade. And as the cases become more complex and you become more knowledgeable, then either you're going to be succeeding at antegrade, but if not, then the next step for most people will be to attempt to do retrograde. Now, if that does not work and you can't do the conventional retrograde wire escalation, we will then switch to one of the dissection re-entry techniques, and that's either retrograde dissection re-entry or with the introduction of the antegrade dissection re-entry device, Crossboss and Stingray, which hopefully we will see that in action in this course. So this is a sort of systematized way of thinking about how you approach a lesion and the escalating level of complexity. So you're going to have to be prepared to fail. So if you don't succeed, if you don't actually even try, you're not going to succeed. But if you do try, yes, you are going to fail at times. And really, the objective is taking your success rate into the 80s and hopefully 90% plus in a very rapid way. So you have to plan cases extremely carefully. The flow of cases and how you react to what's going on during the case is essential. And what you'll see, and I think from all the cases that we're doing today, is that we will try and imbue in all of you that sense of procedural flow. Make a judgment initially on the anatomy, and then how things react during the case, you have to switch strategies quickly. So efficiency, and so that you're not put off in doing these cases, you have to understand that to maintain procedural flow and the changeover within the cath lab is essential for procedural efficiency. It's good for you and it's good for the patient. And your skills will increase as you adopt more and more of these more complex strategies. So you have to then align the skills that you're going to be deploying according to the anatomy of the lesion. And so fundamental to how you plan your case and how the flow of the case will go will be your assessment at the outset of the complexity of the anatomy. And so if you look at the JCTO score, as it increases in complexity then the proportion of these more complex skills that you're going to have to use will increase. So as you'll see, most simple cases, you won't need any of these dissection re-entry techniques, but as you're getting into the very complex cases, there's really a big split between, a halfway split between retrograde dissection re-entry and antegrade dissection re-entry. So very useful tools in the more complex cases. And one of the key things that we learned, and this was at the point that Crossboss and Stingray were being introduced into the market, were that as lesions became more complex, so the longer the lesions, the more tortuous lesions, there was going to be a higher need for dissection and re-entry. So the most common failure mode with antegrade wire escalation is the wire goes into the subintimal space. Previously that was a mode of failure, now that is a mode of success. And it's switching that mindset from subintimal wiring is failure to actually subintimal wiring becomes a mode to succeed. And that's a key switch that many of our Japanese colleagues have yet to make, despite the fact that antegrade dissection re-entry is now a mature technology and has really been, I think, showing its success over the last 10 years. So going back to basics, and this really is going back to being the basics of being an interventional cardiologist, is going back to the angiogram. And it's the systematized approach to the angiogram that you will have to adopt if you're to be a successful CTO operator. So you're making a judgment about the cap. Is the cap ambiguous or unambiguous? You're making a judgment about the length of the lesion. This is quite a long lesion, as you'll see, because you're defining it both antegradely and retrogradely. So you've got a long lesion, and you're then making an assessment of the interventional collaterals. Is this a case in which there are usable collaterals that you could potentially use for a retrograde approach? And then the last thing is really a judgment about the target. Here you can see that the target is at the distal bifurcation, so you'd have to make a judgment, is this an antegrade or a retrograde case? And that's the process that we're going to learn over the course of the next 2 days. Now you can't make a proper diagnosis of a CTO lesion without seeing both the proximal vessel and the distal target. So you have to have 2 catheters. There are situations where there are ipsilateral collaterals, and you can see the distal target from the ipsilateral collaterals, but the general principle should be that dual injections should be regarded as essential. So, the principles of angiographic assessment, you need to perform this in a controlled and stable environment. So, spend some time before the case, if you've got a good angiogram has been done, that you need to study that angiogram, sit down, go through your strategy. And I think this is the reason why cases should not be done in an ad hoc fashion. Hi. So CTO PCI is something that should be done off the cuff. It may have to be done like that in an emergency situation, and certainly we're seeing that more in the primary PCI environment, but that should not be the usual modus operandi. These are elective cases planned in a careful way. I would also commend all of you, if you have access to high quality non-invasive imaging, is that you need to integrate this into your decision making. And I think increasingly now, for the complex cases, we are almost universally using CT. And we're using CT for 2 reasons. One is to see the origin of vessels and the course of vessels, but also to provide calcium maps and looking at where calcium is deposited, and whether or not we're going to have to traverse a long segment of heavily calcified disease, maybe we're going to go around it in the subintimal space, or whether we can choose to puncture through a short calcific proximal cap. Intravascular imaging, Well, as interventionists and non-CTO operators, the rate of intravascular imaging is increasing really at I think, a very pleasing rate for Boston Scientific. They've got the introduction now of the new HD IVUS, which is an absolutely superb piece of equipment. But if you have that intravascular imaging available, I think now probably more than 90% of the cases we're using IVUS. So I'm sorry to be, this may sound a little patronizing, but with angiographic assessment, there are some very basic things that you need to remember. And I make myself blue in the face telling the fellows how to do an angiogram properly, and especially if you're considering CTO PCI. Firstly, if you want to see all the territories, then keep a wide field of view. You may have to do a non-magged view. And then importantly is do not pan. And the reason for not panning is because you increase the resolution of the small vessels, the collaterals, if you don't pan. So I think you should insist on not panning at all. Here you've got, who's, I'm just trying to see, that's Colin there, and that's James. No, who's that? Ah, okay. So here, this is the setup shots, a nice wide field of view. What you can see, assessment of the distal vasculature, you've got a view of the cap, you've got the lesion length, you've got the interventional collaterals. So those four key parameters, cap, lesion length, interventional collateral, and distal target, are there all in one image. Beautifully set up, non-panned, and you can start your case on this basis. You will need to take more than one view, and it may be that in one view you can see the proximal cap well, but you can't see the distal target. But you're going to have to choose those views carefully, and I think it's important to define in your head what those views are and to work between those views for comparison at the beginning and comparison at the end. So here is another case. Cap assessment, so there's a large branch at the proximal cap. So this presents challenges of how you're actually going to penetrate into the antegrade cap, or does this make it a retrograde case? Here doing an assessment of the collaterals. So when you've got your angiogram, and I think one of the key new skills you'll have to acquire is the assessment of the collateral vessels. And one of the things I think, and James I think taught us this at the beginning of our journey with sort of mastering retrograde, was mapping out the collaterals. And there are various ways that you can look at collaterals in more detail. One is to actually map them out on the screen. You can draw them on. You can use image inversion, so going from a dark to a light background and then highlighting the collaterals, and again looking in more than one view. So here's another example. Let's just play this. So really a beautiful, you can see this right ventricular marginal collateral. So this is an RCA CTO, you've got a clear cap here, you've got a wire already penetrated somewhere within the lesion itself, and making an assessment of the collateral vessel. Here you've got collaterals, some septals, you've got this RV marginal collateral. This is giving you a very clear target. So again, all the information is here in these two orthogonal views. You've got your cap information, your lesion length, your interventional collaterals if they're usable or not, and your distal target. Now probably you wouldn't want to use a right ventricular marginal epicardial collateral. So in this case, this is a clear cut. It's either an antegrade wire escalation case because it's a relatively short lesion, or if it's going to go subintimal, then it's an antegrade dissection re-entry case. Probably in this case, I think this would end up as an ADR case. Very nice, straightforward case. So make the simultaneous injections, allow a long run so that you get complete filling of the collaterals. Often there is a delay in you filling the distal vessels and filling the collaterals, so keep your foot on the pedal for as long as possible. Understand the scoring system, and so the JCTO score, I think this is useful if you're doing your case selection at the start. Perhaps get into the habit of doing a JCTO score, because what this is doing is systematizing the way you're thinking about the cap, you're thinking about the calcification, the tortuosity, and the lesion length. So, a tapered cap, yes, a wire will go into this, a wire will go into this, probably get a wire into this. If you've got a blunt cap with a side branch, it's more difficult to get in. But as you'll see, and we'll come to that later in the course, the method of getting into the subintimal space has been refined, and we can actually reliably get into the subintimal space even when there is a blunt cap. So another CTO, a little bit more complex. You're making an assessment here about the cap. You're making an assessment about the collaterals and the distal vessel. Calcification, well, we're going to talk a little bit more later in the course about calcification and some new tools to modify calcium. Of course, we've got rotational atherectomy, RotaPro now on the market. Fantastic iteration of that old technology, but I think is being used actually quite frequently now in CTO cases, including rotational atherectomy in the subintimal space. We also have the introduction of intravascular lithotripsy, but has yet to find its position within the CTO space. But calcification is important because it determines the types of wire you're going to use, and whether or not you choose an approach to go through or go round. And so assessment of calcification, useful from CT, but also hopefully you can see it on angiography, is factors into your JCTO score. So here you can see some calcification here, you can see the proximal cap. This has been recanalized, but calcium here really does increase the level of difficulty. Sometimes it can be your friend because it can actually define the vessel course for you. You can see the calcification, you know where you're going. Tortuosity and assessment of tortuosity is also important. Now, if you don't know whether a vessel is tortuous or not, then you have to assume that it is. If you don't know where the vessel is, assume it's tortuous. And that will ensure that you avoid using penetrating wires which will exit on the corners, rather than a hydrophilic wire, a polymer jacketed wire, which will stay within the vessel architecture. So tortuosity is important, and is especially important when you're considering subintimal approaches. So here another complex case, very tortuous vessel here, and we're just showing how you can use, so this vessel tortuosity, extreme angulation in the vessel. Remember, in this situation, if you've got a penetrative wire, so a wire like a Confianza Pro 12, and you push this wire out of the microcatheter and you don't know whether you're going to be going straight or round a corner, then you're going to run into trouble. So this is really part of the principles of working in the subintimal space and working with polymer jacketed wires that are important. Now, CTO length is sort of self-evident that the longer the lesion, the more chance there is of you going off course when you're trying to get from one end to another. So the cutoff value that we have in our head is around 20 millimeters. So if a lesion is longer than 20 millimeters, there is a significant increase in the rate at which you're going to go into the subintimal space. So that factors into your JCTO score. Now, if the lesion has been tried before, that has really been used as a marker of difficulty, and that gets a point within the JCTO score. So you're looking for vessel tapering, calcification, the occlusion length and tortuosity, and whether it's been done before. Now what about the quality of your distal target vessel? Now one thing that makes the CTO operators, and when we're going and doing proctoring, is going to do a case where the distal target is very poor, either very small, very heavily diseased, very heavily calcified, or you can't even see it at all. So the quality of the distal vessel, this is really what you're trying to open up, is important in your decision making. Now, coronary artery bypass surgery, and especially saphenous vein grafts onto occluded right coronary arteries, not a good treatment. Sorry to the surgeons in the room, but anyhow, they present to you a golden opportunity. It's a great retrograde conduit. I mean, maybe that's what they've been put there for. But having that information from your angiogram is useful, but the CT scan is also very useful in that regard. So, this lovely slide from James. So let's go through lesion length, 20 millimeters, calcification, no, tortuous, no, blunt cap, no, previous failure, no. So JCTO 1. So this is a good, apart from the fact that it's just near the left main here, or an osteal LAD lesion. Should be a relatively straightforward antegrade wire escalation case. Well, what about this case? So let's go through again. Can you see that anatomy there? Lesion length longer than 20. Is there calcification? Well, you can't see this angiographically, so we'll say no. Is there a degree of tortuosity? Yes, we think so. Can we see the cap? Is it a blunt cap? Yes, it is. Hasn't been tried before. That's a JCTO3. So, you're going through in this systematic way, dual injection. You're looking at identifying an ambiguous proximal cap, a poor distal target, good interventional collaterals, major side branch at the distal cap. Answer those questions at the outset, yes or no. So if it's not, you don't have an ambiguous cap, you're going to be going antegrade. If it's less than 20, antegrade wire escalation. More than 20, antegrade dissection re-entry. That's a fairly simple way of dividing up your antegrade cases. And certainly if you don't cross with a wire, with antegrade wire escalation, and you end up inadvertently in the subintimal space, you can then go to antegrade dissection re-entry. Now conversely, if you have some degree of cap ambiguity, or there is a major side branch at the distal cap, so remember that very first angiogram we saw with a distal bifurcation, quite a common finding, PDA, PLV system, distal RCA bifurcation. Those are cases that really have to be done retrogradely. And if they're short retrograde lesions, then retrograde wire escalation. If you don't cross and you don't manage to re-enter the guide, then you're going to use reverse cart technique and retrograde dissection re-entry. So 4 things that you need to assess at the start, decide your 4 strategies that you're going to deploy. So it's the anatomical factors that dictate what you're going to do. They dictate the strategy. What they're not doing, because you've got over that problem about whether it's indicated or not, they're not telling you whether or not you should do the lesion. That decision is, that ship has sailed. So this is about anatomy dictating strategy. So what about this one? What do we think about? Is this an ambiguous cap or not? What, show of hands, ambiguous? Yeah. I mean, really, this is really one of those unusual situations with a very, very mature antegrade collateral. You can't really see where the cap is. What about the lesion length here? Long? Yeah.
Yeah.
Distal cap here at the major bifurcation? Yeah.
Yeah.
So this is almost certainly going to be a retrograde case. Now you could, and we can have that debate and we can discuss that whilst we're doing the cases, is should you always try antegrade first? I don't think so. I think we know enough about how wires are going to behave. We know enough about, we've done these lesions, many times, that this would be the case for doing retrograde. Now, if this isn't a case that you can do at your current level, then either get somebody to come and do it with you, bring a proctor in to do it, or send it to somebody who can do it. Now, the degree of disease in the distal landing zone really does make an impact on antegrade dissection re-entry and the difficulty of re-entering the vessel where there's disease. Initially, when we started with ADR and cross-pos and stingray, that we were trying to avoid segments of disease which were more diseased. We were always trying to re-enter into a healthier vessel. That isn't always possible, and now I think we have some good strategies for the more sort of difficult high-end ADR type cases. Now, the quality of the interventional collaterals. You'll find yourself as you start doing retrogrades that you sort of secretly start getting excited about collaterals, and when you start doing looking at angiograms with your CTO hat on, then every time you're doing that, think about the collaterals. Think about the septal collaterals. Think about your epicardial collaterals. There is a beautiful piece of work done by James and Margaret McIntaggart looking at the classification of collaterals. There are some educational tools that we'll mention later which will help you with that. In fact, this is it. So, a guide to mastering antegrade CTO PCI has just been released.